Great, Joel. Thank you very much for the invite, and thank you to the IPC for hosting. I'm very sorry I can't be in Portland, but I believe the weather in Newcastle is actually better than Portland today, so that's a bonus of being remote. Here are my disclosures, and I've listed bad beer, which is a major focus of the talk. And as with other registries, this receives funding from pharma, but I think it represents as we've just heard from Stephen, a very good collaborative environment. The primary reason for bad beer was pharmacovigilance, but because of the collaboration, we've been able to collect lots of different kinds of data, which has informed not only adverse event reporting, but efficacy outcomes. And so this slide provides an overview, and like both April and Stephen, who set the scene tremendously well, I'm going to discuss some of the strengths and weaknesses of registry data. I think one of the things to say is, obviously by definition, you're collecting data with a specific purpose. So the fields that we wanted to collect were defined very carefully at the beginning, and they've largely remained unchanged. We have linked to some UK-wide data for certain outcomes, but in general, the advantage has been that we've collected the data in one setting, i.e. in a hospital outpatients. We can perhaps talk later about the issues about comparing registry and real-life data, but in the UK, there is still an issue about joining data sets together of primary care and secondary care. And in the UK, the majority of severe patients are treated in a hospital setting. So that's an advantage of the registry data. Clearly, because these are longitudinal, we were able to collect efficacy data over a long time. And as we've already heard, the adverse data can be much more informative over many years, which we wouldn't get necessarily from randomized controlled trials. I think one of the exciting things that's coming out is the real life data gives us the opportunity to predict response. And then finally, in line with the other speakers, I'm going to briefly mention how this data feeds into regulatory and advisory work and bodies. So this has been really covered to a large extent. So I just highlight a couple of points. I should say that bad beer was powered according to certain key outcomes, in fact, non-melanoma skin cancer, which we'll come to later. And so it's important to look at how the study was designed in order to inform the questions that you're then going to ask. And there's no doubt there that because of the way that these things have evolved over many years, we have got large samples compared to randomized controlled trials. And this does allow us to report on these two key issues, efficacy and adverse events. And importantly, we are now detecting rare events in registries, not very rare events, and we'll perhaps come back to that. I think the other thing that we'll again discuss a bit later is relative efficacy, which is something that is you can get from very carefully designed randomized controlled trials, but not multiple comparisons easily within one data set. So this is a key advantage of registry data. There is an issue about what your outcome measure is. So drug survival, as reported here by Antonio Constanzo, is one of the key things that is used as, if you like, as an all-encompassing measure of efficacy, which takes into account effectiveness. It also takes into account adverse events, because if people develop those, they will stop, patient satisfaction. And so it's kind of a conglomerate measure that has proved a great utility in a number of our registry studies. And we're increasingly starting to think about, can we stratify patients according to the order of play that we should use biologics? And we're really now in a position where we can start to use AI and machine learning to high utility, and I'll illustrate that towards the end of the talk. This point has already been brought up, but it's really important to emphasize that remarkably 30 to 50% of patients in trials who we see in the clinic wouldn't be eligible for a trial. And so what you're really seeing in trials is a subpopulation of people we're seeing in clinic. And as a practicing physician, you really want to know, is the trial generalizable? And so that's something that we can really offer by registries And again, I think the point of integrating clinical trial data and registry data is extremely valuable. One thing is it clearly takes a long time to collect registry data that's going to have significant information to the field. So there's a lag phase, probably greater than in randomized trials. And it's clearly not randomized, but I think the development of a propensity scoring, which we've applied to a number of our studies, has unlocked this to a great degree and tends to remove the issue of selection bias. Clearly, you've got to decide which of the potential confounders you want to control for. But a good example is psoriatic arthritis. And so here you can see that psoriatic arthritis is clearly a selection factor in which biologic you're going to choose to give your patient. It's also going to affect your outcome, your reluctance or wish to switch drugs. Maybe, if you're controlling psoriatic arthritis well, how does that affect your decision if your psoriasis starts to flare a bit? So it's a very complicated interaction. So clearly you want to balance this if you're comparing drugs across arms, and the propensity scoring is essentially a matching score that enables you to match your cohorts in a way that means that you're kind of doing a subset within that registry data, and it's mimicking a randomized controlled trial. It's a bit of an oversimplification, but I think it's a very useful technique that we've applied with good effect. Missing data is a real issue. Clearly, patients don't always attend when they should. So it's largely in registry data, the time of collection may be an issue. And we've used various forms of imputation to account for that. I've already discussed the survival analysis, which we think is key to measuring efficacy and effectiveness. And there is an issue with PASI measurements in registries. We do measure this very regularly in bad beer, but clearly there are washouts before baseline, before you switch drug. And so what is a true baseline? We've had many debates about what that really means. We think it may be more helpful to look at treatment to target of low PASI, less than 2 or 3 as a target to analyze for. So those things I think are important when you're bearing in mind the pros and cons of what the data means. And it's clear that even in these large registries, we don't have sufficient power for very rare events. And certainly in Europe, that there is a system that enables us to join up with colleagues. And for very particular questions, we've enabled data sharing or pre-analyzed data. And, the field has no doubt been stimulated by the biologics revolution, which not only has impacted patients to a fantastically beneficial degree, but has also stimulated a lot of activity looking at real life data that perhaps wouldn't have occurred without it. So when the first systematic review was done back in 2016, there were just 4 registries that were identified. But even a few years later in 2019, there were 13 psoriasis patient registries in Europe. So that's a remarkable amount of data being collected in real time by our colleagues. And we should really make the most of this important data set. One of the great things about bad beer, and I've been privileged to be part of it since its inception, it's led by Chris Griffiths' team in Manchester, but it really is a UK and Ireland network. And we've got 156 centres collecting data, which means it really is representative of the whole of the population, which is greatly geographically different, demographically different. And I think that really increases its external validity. And I think the numbers pretty much speak for themselves, but we've got more than 20,000 registrations, over 14,000 on biologics. And importantly, we have got a variety of controls now that we can use, the conventional cohort and increasingly the small molecule cohort. And it's, I think, clear to anyone who's been working in this field that the patients who are now entering these registries are rather different to those who entered at the beginning. And so what is a contemporaneous control? Some people have argued we don't need a control group anymore, but I think we need to have a time sense of events. You can't necessarily use historical controls for these patients. the amounts of drugs that are available now are very different to what they were 15 years ago. So I already mentioned there's 165 sites across the UK. Importantly, we're continuing to recruit to bad beer. It's slowed down a bit because of different companies contributing and pulling out over time, but we're maintaining this follow-up as much as we can for those already in. And it's an enormous amount of work collecting the data by individuals in these 165 sites, as well as the coordinating center. And we've been very productive, over 31 journal articles published from bad beer, really enormous years of follow-up. And we've now got 31 different drugs within the registry. And we're not into league tables, but I would put bad beer at the top in terms of being the largest registry as far as we can tell. So now I'm going to give you a few examples of data that I think you're not going to necessarily get from randomized controlled trials. And collecting this data is a combination of registry data, but also real life data from France in the second example. And these data show remarkable alignment. So bad beer data published in 2019 that infliximab had a clear and statistically significant increased rate of serious infection, which fits in with our clinical observations. Here, serious infection is defined as that's sufficient to lead to hospital admission, intravenous antibiotics, or death. So almost double the rate compared to non-biologic systemic drugs. And virtually the same kind of data has emanated from a complete study of more than 40,000 patients on biologics in France through their national health system, essentially. And again, very similar adjusted risk ratios for infliximab, but notably they also found an increased rate for adalimumab of 1.2. And this data is also consistent with that from other registry data and other real-life data in other fields, such as rheumatoid arthritis and inflammatory bowel disease. And I think this study, published back in 2015 from the Lancet, is still very important because, again, it shows, in terms of serious infection, that there is an increased risk, particularly when you get a high-dose biologics, and notably to combination biologics. And we're starting to see that now in our field for the very resistant patients, maybe combining one or more biologics or novel small molecule with a biologic. And we need to understand the implications of those decisions for our patients. Non-melanoma skin cancer, I mentioned, was what we powered bad beer on. So according to that, we had sufficient power when we performed the analysis last year, published in the Journal of European Dermatology, JEADV. So interestingly, we didn't show an increased rate of BCC or SCC in the whole population. We were able to exclude a twofold increase, which I think is clinically important. But we did see an increased rate in older patients on biologics, more than 60 with a hazard ratio of almost 2 again. Another important question that everyone's interested in is melanoma. And again, there aren't many studies yet coming out on that. The power to detect these rare events is still not there in individual registries. So the systematic review that combined data, I think, is worth having a look at. You can see that overall, in the forest plot with the IBD and RA data, it doesn't approach statistical significance, but it's definitely moving that way if you look at the studies lined up. So as we collect more data, it's an important thing to watch for. And there's only one study I'm aware of in psoriasis. Again, that was non-significant, but it's something that's very important to us as dermatologists to watch out for. Reassuringly, overall, if you look at, for example, TNF inhibitor therapy, again here using a Danish population study with almost 30,000 patients with immune-mediated disease and a history of cancer, they then were able to look at these patients carefully for matched controls, which they matched 10 to 1 for non-biologic systemics, and they found no increased rate for new cancer, and also no increased rate for recurrent cancer. And I'm sure we're all meeting these patients in our clinic, and we have difficult therapeutic decisions to make about what to do with them. Generally, we tend to stop biologics at the diagnosis of certainly widespread or systemic cancer. But again, as we collect more data, we may be able to help our patients more in that area. So the next few slides illustrate comparative effectiveness, again using survival data. So here we're looking at the numbers of patients retained on a drug over time. And you can see that the first paper published back in 2020 showed that there was a clear survival difference between adalimumab, secukinumab, and ustekinumab. So a clear drop in survival, patients switching to another agent or stopping, compared to secukinumab and ustekinumab, which showed very similar survival curves. And then more recently, this data was presented by Zenas Yu at the Gene to Clinic meeting, currently under review, with some of the more modern biologics now in sufficient numbers to be able to report on this. And you can see that guselkumab appears to be the greatest survivor drug amongst the ones studied here. Again, adalimumab consistently shows the worst outcomes in terms of efficacy survival as we measure it here. And importantly, one of the things that also comes out of this real life data is the order in which you give the drugs, which is a clinically relevant question. So it does appear relevant if you give secukinumab first, you get a better overall survival than if you give it as second or third line, shown down here with the lighter blue color. Whereas some of the other biologics show much closer approximation, not necessarily so affected by the order in which those biologics are prescribed. So this is helping us make decisions in the clinic given patient context. So I mentioned that one of the exciting areas of development is, can we actually predict how patients are going to do on any given biologic? Clinically, it's been clear for a while that BMI is a factor, and this study published a few years ago definitely showed BMI as an adverse factor of outcome. So an increase in 5 units of BMI reduced effectiveness by about 12%, and adverse events were increased by about 17%. So a clear factor in there. And we found similar things when we looked at the bad beer data. So weight, profound effect if you were 110 kilograms or more. But we've also found that white ethnicity was a good prognostic factor. And interestingly, clinical issues like palms and soles were a poor predictor of outcome. And gender was also important, as was smoking, social economic class, and unemployment. But overall, these data show that the variance that's predicted by these clinical demographic factors at baseline is only about 10% towards the outcome. So we definitely need to combine this with other kinds of data, particularly biomarker data. I've already mentioned that I think AI is a very exciting area, and this paper came out back in 2021, where latent class analysis was used to look at the longitudinal pattern. So that's the other advantage that you've got with registry data. It isn't just individual data points. You can look at how patients' trajectories change over time. And by this computer machine learning algorithm, 4 different classes of shape of response were identified, and even by eye. You can see here are the summary lines. You can see that class 1 shows gradual but not great improvement. Classes 2 and 4 show rapid improvement, but then some degree of rebound as they go into a longer term follow-up. So these do appear relevant, and what's really important is they show clear association with both genetic factors. So class 3 was associated with HLA-CW6 status, but also some of the clinical factors I already mentioned, like BMI and PALMS and SOLS, correlate with these groups. And they also correlate with palsy outcome at an early time point of 4 to 8 months. So you can see that this group really doesn't do so well. And in fact, the groups that seem to do best are those that then show some degree of rebound. And these patterns, I think, are really important in telling us something about the biology of the disease, as well as the clinical response to particular biologics. I should say that when we split the biologics, that the numbers weren't sufficient at this point to be able to distinguish clear effects between different biological classes. So this is looking at biologics as a whole. And this again illustrates that class 1 again show a greater degree of switch, consistent with that being an overall measure of our overall treatment effectiveness. Finally, I think this has been covered in an exemplary way by the 2 previous speakers. So I think in dermatology, and certainly in the psoriasis field, it's still the case that trial data is crucial for the licensing of drugs. But I think as we start to use these drugs in rarer diseases, the registry data could become very important. There's no doubt there that registry data informs guidelines, and certainly how we use drugs in clinical practice is influenced by the BAD guidelines as well as the European guidelines. And I think physicians definitely need help and consensus about what to do in particular tricky circumstances, pregnancy, and difficult circumstances like patients developing cancer whilst on a biologic. And as you may be aware, in the UK, there is an advisory body, NICE, that looks at clinical effectiveness in terms of economic assessments, and so how that feeds into the decision making of both to make sure the NHS is getting value for money, and clearly their real life data is very important for the recommendations it's going to make for being used in the field. It doesn't just want to rely on trial data. And I'll finish just by hoping that I've convinced you that real life data, it does give very important and interesting finding that I think is undoubtedly changing how we practice clinically. The data is becoming more complex just because we've got more data over time, and we're starting to integrate it with other data sets. And that really brings in the conventional data analysis needs to be adapted, and AI and machine learning brought in and used alongside routine epidemiological analysis. And I would also, I mean, it's great that we're all on the same page here, because I think that we really do support partnerships, collaborative working across countries, academia and industry. And I think through that, we have made significant inroads, and I hope we have benefited our patients.
That was terrific, Nick. Thank you so much.